third session of the module 1 on non-muscle invasive bladder cancer. We have covered about TURBT in various situations. We have talked about the follow-up. We have talked about stratification. Today's topic is essentially about the treatment of non-muscle invasive bladder cancer. We're going to talk about intravesical chemotherapies, intravesical BCG, and then subsequently BCG failure. We know that BCG is one medication which has made a huge impact on the management of non-muscle invasive bladder cancer. The story started over 100 years back with the BCG vaccine developed by Bacillus Calmette-Guerin in France. And from there on until 1976, Alvaro Morales wrote that classic paper in the Journal of Urology in 1976, talking about the intracavitary use of BCG in the management of what used to be called as a superficial bladder cancer. Now, this is a long story, and anyone who's interested in that story can visit this website, and where I've talked about how BCG vaccine for tuberculosis has become the BCG treatment for non-muscle invasive bladder cancer. It is a wonderful agent. It works very nicely, and Professor Prem Gyawali is going to talk about how BCG works and how effective it is. We still don't know very clearly exactly how BCG works, and there are various theories about its functioning. So today's program are 3 presentations, and our 3 speakers are Elsie Mensah. You have heard her before in the first session on TURBT in R block or piecemeal. She's a consultant urological surgeon at Guy's and St. Thomas's Hospital in London, UK. We have Professor Prem Gyawali, who's a professor of urology and kidney transplantation, associate dean academics in the Institute of Medicine in Kathmandu in Nepal, an old friend and a real supporter of all academic activities taking place by PAUS. And then we have our own Mr. Mazhar Sheikh, consultant urological surgeon, Blackpool Teaching Hospital in England. And Mazhar has been a regular part of the conceptual basis of urology course, big supporter of urological activities in Pakistan. So with this, I welcome you all 3 speakers and all the delegates who are attending this course. Just a brief recap that after today's session, the next session is on 16th of November, and in which we are going to discuss 3 interesting cases, if time permits, or 2 cases of non-muscle invasive bladder cancer and how they are managed. And you'll be in a situation to apply the knowledge that you have gained from this module in the 9 lectures that we had in this module. And then subsequently, we're going to run a post-test, again, on a very similar ground that we had a pre-test before the session. It will be 45 minutes, 30 questions, and you'll be scored accordingly. So without any further ado, may I ask Mr. Mazhar Sheikh to please share the screen and start your presentation. I'll stop unsharing. I'll stop sharing. So, Mazhar, the screen is yours.
Good afternoon. Thank you very much, Professor, and welcome to all the delegates. As Prof has said, like Mazhar Sheikh is my name. I'm based in England. Can you look at my screen? Can you see this, Prof?
Yeah.
Okay. So the topic that I'm going to cover is role of intravesical chemotherapy in non-muscle invasive bladder cancer. Just a brief layout about the TNM classification. I think for us, either at any level we are working, we need to be very careful regarding knowing the basic knowledge of bladder cancer, which many of the times is not a very, it hasn't taken that much attention, especially in the presence of prostate cancer. So there's a lot of research that should be put on. In UK, as we all know, bladder cancer as part of other cancers will be followed through a fast track pathway. We follow the 2-week wait pathway, and they've been stratified into their risk factors and their characteristic. In the previous session, we have discussed about the TURBT and how to have the optimal management of bladder cancer. This is one of the cancer who has the tendency of recurrence very frequently. So that's very important to know what are the mechanisms that are involved in the cancer recurrence. Unfortunately, still we come across many patients who have incomplete resection for many reasons. We can have tumor cell reimplantation, growth of microscopic tumors, and don't forget the new tumor formation. We are all aware of the significance of secondary resection or early resection, but at the same time, I cannot stress more regarding the primary TRB to be complete, and I don't suggest not to be a bit radical as far as you have considered the patient factors and disease factors. We
Sorry,
know
Mazhar, may I request you to please go on to the presentation mode? The slides are a little smaller. They will.
Oh, is it okay? Thought it's been on the slideshow. Apologies, Prof.
From the current slide.
Prof, I'll just go from. Is it better now,
Yeah,
Prof?
that's fine. Yeah, it's much better. Thank you.
Thank you, Prof. So as I was telling, just mentioning about the importance of second TURBT or resection, that the objective is, which is well evident, that we have recurrence-free survival. It provides prognostic information and also improve the outcome of intravesical therapy like BCG. Despite having all the modalities available, still we do come across that persistent disease after primary resection in T1 up to 50%, and high-grade disease that can be compounded to over 40%. And it's not only seen in underdeveloped, it's a global phenomena. So again, we need to be very careful about the primary resection. The studies have shown that muscle-invasive disease can be found on second resection in T1 disease, ranging from 4 to 25%. And unfortunately, that can increase significantly if the primary TURBT has not muscle involved. So based on the recurrence and the parameters as discussed earlier by me, we can see there is a strong role if it is a high-grade disease with PT1 involvement. The disease can change significantly and can become muscle invasive. Now, we are all aware of the EU risk stratification based on the low risk to very high risk. We are all aware of if the disease, the patient group is less than 70 years, primary tumor low of less than 3 centimeter, and without carcinoma in situ, they can be put in low risk. However, on the other spectrum, if all those factors along with PTA or any high grade, along with carcinoma in situ and these risk factors, disease can be characterized as a very high risk disease. We are aware of the NICE bladder cancer risk classification, which is not very dissimilar to EAU, apart from in this group, they have no very high risk. They have compounded into high risk group. Just touching briefly regarding based on the local logistics, we do modify the follow-up strategy, but we should have some kind of mechanism to have the best outcome for the surveillance of these bladder cancer. In intravesical chemotherapy, as we are aware, for the intermediate risk, we need to be more vigilant about it because we want to catch this disease in the group when it can be treatable. So we are all aware of this non-muscle invasive bladder cancer EO scoring models, and this is the parameter that has been used worldwide that help us to stratify the patient group and the probability of their progression. Never underestimate the significance of carcinoma in situ. So in any patient group we see CIS, we need to be very, very proactive. We are all aware of Sylvester's studies. He has done a lot of work regarding the non-muscle invasive bladder cancer, the chemopreventive role, immunotherapy roles, and all these studies have shown that BCG can be more effective as intravesical chemotherapy, which my colleagues will be discussing later as when we talked about BCG. Now, going back to intravesical treatment, I feel intermediate risk group is the most important one when we are talking about intravesical chemotherapy, because we don't want this disease to be missed. So going to the topic, intravesical chemotherapy can be divided into chemotherapy and immunotherapy with BCG. The commonest modalities among the agents we use are mitomycin, epirubicin, gemcitabine are also used, and they have different mechanism of action. If you look at the mitomycin, which is in our practice the commonest intravesical chemotherapy used it inhibits DNA synthesis. It's an antibiotic chemotherapeutic agent which affects and works at the G1S cycle of cell phases of the cell cycle. It has an ablative effect on the tumor cells and also on the circulating tumor cells. In my practice, and most of our urologists based in UK, if there is no contraindication after primary TURBT, we install within the theater and clamp it ourselves to further reduce the chances not of any problem in recovery or so forth. So after the primary resection, we give intravesical in 40 milligrams preform vials and keep them to about an hour or so. As part of the urology fraternity, we know there is a strong evidence regarding the role of mitomycin in disease risk reduction, which is absolute 12%, and relative risk reduction is 39%. And again, we know it's a standard of care to give intravesical one dose immediately after resection. Sylvester has also recently updated the data in 2016, which also covered this aspect. So as I alluded, it's a standard of care of a patient after primary TURBT. Going through the other agent, which is epirubicin, another intravesical agent, it inhibits nucleic acid, DNA, and RNA synthesis through multiple mechanisms. The commonest one that we know about, it inhibits anthracycline topoisomerase 2 inhibitor. So it affects thereby by blocking the mechanism between intercalation between base pairing. So that's how it inhibits the enzyme that stabilizes the DNA topoisomerase 2 complex. So use of intravesical chemotherapy, we have briefly touched the commonest modality in the form of immediately post-operative installation. We can talk also about the installation as a cyclic regime. As I have already alluded in my prior presentation regarding the risk-related and the commonest use of this agent, and it has shown if it has significantly reduced the risk of recurrence in 1 year and also at 5-year interval when the patients were followed. We know the rate of progression is clinically significant but lower at 6% at 5 years. So in studies as shown, it also not only reduces the risk of recurrence, progression, we know it's comparatively based on if you're giving the chemotherapy as a course rather than single installation. We have used other agents as well, like gemcitabine, and we found it is superior than the other agents. We are all aware of patients who are not suitable to have immediate intravesical therapy. Even if we do give them slow irrigation of saline, the recurrence rate has been found lower than the control arm. So additional adjuvant intravesical chemotherapy installation. So that based on the risk stratification, and we need to define if they fall into the intermediate risk group, like patients who are not low risk or they are not high risk, like they don't have CIS. This is the cohort of patient that we should consider and discuss through MDT process regarding the utilization of intravesical mitomycin or epirubicin. Regarding the length of and the frequency of these intravesical chemotherapy installation is still not clear, but we have a strong evidence based again by the studies by Sylvester that it should not exceed over 1 year. Um, there is no role of maintenance chemotherapy over induction in the management of non-muscle invasive bladder cancer. So, as contrary to BCG, intravesical chemotherapy has not established role of maintenance therapy. So now, apart from the intravesical chemotherapy in the form of induction and cycle, can we give them in the combination in a cohort who are not responding to just 6 weekly cycle or so? The studies have been done which have a combination therapy with BCG, which I think my colleagues will discuss more in detail regarding the role. So we need to be careful regarding the patient and the outcome, because if we combine these agents, they can be very toxic. So we need to be mindful about the limitation, because at the end of the day, we want to treat our patients who have the cancer rather than just treating the cancer. Now, there are some modalities or mechanism which can help to improve the efficacy of intravesical chemotherapy, like by adjusting the pH, the duration of installation, and the concentration of these drugs. They have been looked into and they have a positive impact, but again, we don't know completely. So they are not recommended as a standard of care, but these are the changes that can be altered and improve the outcome. We are all aware of these devices which have been used to improve the absorption of these intravesical chemotherapeutic agent. Increasing the temperature has been used for a long time regarding improving the efficacy of these agents. The way the hypothermia improves the outcome is basically it improves the drug delivery into the system. We know by increasing the temperature, the chemotherapeutic agent can become more cytotoxic and they improve the sensitivity of these therapeutic agents. There are already established role of increasing the temperature will regulate the immune factors, so that can have an augmented effect. So that's just an illustration how the device is used, increase the temperature, and through the catheter, the chemical installed in the bladder. I recently have a patient who unfortunately was not the fittest person. She's in 80s. She's despite having a multiple course of mitomycin. We have even given her BCG. She couldn't tolerate it, so we have to go for hyperthermic mitomycin, and the results are reassuring. She didn't get any recurrence. So there are role of hyperthermic mitomycin or other modalities. We know the role of salvage therapy in these settings. They can be discussed in later, but as I have mentioned earlier, we need to know more about these agents and in combination, and especially those non-muscle invasive patients who are not cystectomy candidate, but we have limited resources to help them and improve their cancer control. So the studies have shown that if you combine different models together, we can improve the cancer clearance or cancer-free survival, but still it's not the standard of care. The other endpoint of these studies have been that we don't want these non-muscle invasive bladder cancer to become muscle invasive, because then the paradigm of treatment will alter completely. Uh, as far as the salvage therapy is concerned, valrubicin is the only FDA approved drug that can be used to patients who have BCG refractory CIS. But I think I'll leave my colleagues who will be discussing about this in the future. Um, so, as I mentioned earlier about these patients who can be treated with other modalities. So, if the chemotherapy failed in non-muscle invasive bladder cancer, where do we go from there? We have tried different chemotherapeutic agents. One option is to combine with BCG. The other is try different groups of intravesical chemotherapy. Now, based on the EU guidelines, we are aware of that in patients with low risk non muscle invasive bladder cancer, small recurrences detected more than 1 year after primary TURBT, uh, we can reduce significant the recurrence by giving only TUR. So, if a patient has only TURBT, and if you give him an intravesical one shot, that significantly reduce the chances of recurrence. There is no effect in the disease progression, but the recurrence can be improved. Um, if you look at the confidence regarding the repeat chemotherapy, um, in the risk group, I think it's not clear that we're going to help the patient who are having recurrences in this immediate risk group. So in my conclusion, intravesical chemotherapy has a critical role in the treatment paradigm of non-muscle invasive bladder cancer. The current evidence support the use of intravesical chemotherapy within 24 hours of TURBT. We try to give it within as early as possible, but as you know, the logistic can be challenging. And we also know about the shortly after nephrectomy, there is a strong role of giving one shot intravesical treatment that helps the recurrence. Intravesical chemotherapy for specific patients in intermediate disease, as we are aware of, there is a role. An appropriate schedule is currently unknown but should not be beyond 1 year. In high risk disease, adding intravesical chemotherapy to BCG can improve outcome, but in exchange of higher toxicity, there should only be considered in the highest or very high risk patient group where we are concerned about disease progression and becoming muscle invasive. We are urologists. We don't forget the rule of radical cystectomy, but as I mentioned earlier, we are treating patients who have cancer, not only cancer. So I think there is a role having a proactive and pragmatic approach when we're discussing these issues to our patient. Thank you very much.
Thank you, Bazar, for completing your presentation bang on time. Just one question to you about the maintenance MMC. I mean, we know that they are very clearly laid out scheduled for maintenance in BCG. However, the same is not true for MMC. What is the one that you follow and in which patient?
Excellent question, Prof. We tend to go for once a week for 6 weeks, and if the patient after that, normally we don't go for maintenance, Prof. In our practices, most of the time, if the patient has not responded to weekly course of mitomycin and they have bladder capacity is okay, we discussed in our network MDT regarding BCG or continuous surveillance. The other option we are exploring is hyperthermic mitomycin. So in real time practice, Prof, maintenance BCG is not that practical, although it sounds a very good option.
Thank you. Can you please unshare your slides so that Professor Gyawali can share the slides? Our next presenter is Professor Prem Gyawali. Most of you know him very well. An established figure, an academician in the South Circle. And he's going to talk about BCG, the wonder drug for non-muscle invasive bladder cancer. Professor Gyawali, platform is yours.
Okay, am I sharing this? Can you see my slides?
Yes, we can, sir.
You can, yes. Okay. First of all, I would like to thank Urology department in collaboration with Pakistan Association of Urological Surgeons and South Asian Association of Urological Surgeons, and especially Professor Hamad Athar for providing me this opportunity to present my talk in this forum. The topic given to me was intravesical BCG for non-muscle invasive bladder cancer. Actually, while talking about any topic, I like to go in a little history of that topic. Few slides were shared already by the Professor Hamad. That history of BCG starts from the last almost 100 years ago, when Paul published about in his study of the autopsy series, where he found lower rate of cancer in the bladder who had suffered with the tuberculosis. And even they have found that the people who got the vaccination with BCG vaccination for tuberculosis, the chances of leukemia in children was less. It was published in American Journal of Epidemiology in 1929, and Holmgren also published in 1935 about the antineoplastic nature of the BCG. But most the you mean record-breaking status comes from 1976, when Alvaros Morales published his series of intradermal and intravesical installation of BCG. He instilled 120 milligram of BCG weekly basis for 6 weeks. It was published in 1976. It was the landmark study about the BCG. Southwest Oncological Group, they randomized a trial in BCG maintenance, which was later published by Donald Lamb in Journal of Urology. So here we are talking about the non-muscle invasive bladder cancer. It means carcinoma in situ, urothelial papilloma, and T1 disease, which doesn't reach to the detrusor muscle. It is a few slides may be repeated. Please bear with me. This is seventh most commonest cancer in male. 75% of the bladder cancer are superficial when they are diagnosed, and the peculiarity of the disease is that it is multifocal. Multifocality can be synchronous or metachronous. There are two theories about the multifocality of the tumor. One theory is that it is a monoclonus distribution or extension of the tumor intraluminal or intraepithelial way, or the field cancerization. It means the normal urothelial cells are replaced with the precancerous cells. So there are subclassification of T1 stage also. In clinical practice, we do not use this classification. There is no division of T1 stage, but T1 is also subclassified into T1M and T1E. T1M means it is microinvasive, that the focus of the lamina propria is invaded with the cancer in less than 0.5 millimeter. It is micrometric. If it is extensive, it is known as T1E, when the invasion of the lamina propria is more than 0.5 millimeter. Histoanatomically, if the tumor does infiltrate the muscular mucosa, then it is named as T1A, and if the infiltrate does not infiltrate, it is T1A. If it infiltrates the muscularis mucosa, it is T1B. Definitely the progression rate and the recurrence rate with the dose type of the tumor is significantly different. So issue with the non-muscle invasive bladder cancer is that in 5 years, 75% of the non-muscle invasive cancer, they reoccur. 20% progress to the higher stage. 30% of the superficial, actually we do not pronounce the terminology superficial nowadays. We say it is non-muscle invasive. 30% fail to respond to the BCG. So are there any prediction about the which cancer is going to reoccur, which cancer is going to progress? It is still difficult to answer. That's why the risk factor here are the number of the tumors. The more the number of tumors, chances of recurrence is high. The size of tumor, if the tumor size EORTC has given the fixed size of the tumor if it is less than 3 centimeter and more than 3 centimeter. If the tumor size is bigger than 3 centimeter, the chances of recurrence and progression is high. If there is a recurrence of the cancer, the disease is going to reoccur and progress more. It depends, the risk factor depends upon the stage of the disease, and always carcinoma in situ is always very, very high risk cancer in bladder cancer. In other organs, carcinoma in situ, when it is diagnosed, they are happy that they could diagnose in very early stage and the prognosis is very good. In case of the urinary bladder cancer, carcinoma in situ, the prognosis is grave, and it also depends upon the tumor grade. So already our previous speaker, Dr. Mazhar, presented this slide. European Association of Urology Guidelines has classified 4 groups, risk groups. In low risk groups, the tumor is primary, it is single, low grade, and smaller than 3 centimeter, it is low risk group. If the tumor is primary but multiple, still it is low grade, it can be the intermediate, or it doesn't fall between, it doesn't fall neither into low risk or high risk, then it is intermediate. In a high risk group, any tumor with high grade and the size is bigger than 3 centimeter is also taken as a high risk group. But if you can see here in this slide that any carcinoma in situ of the urinary bladder, it falls into very high risk group. So carcinoma in situ has a very grave prognosis. Probability of progression depends upon the risk group. If the risk group is low, 1 year progression is 0.6%, 0.06%. And in 5 years, it is not even 1%, it is less than 1%. In 10 years, the progression rate is 3.7%. If you go in very high risk group, progression in 1 year is 16%. Progression in 5 years is 43%, and every second patient, more than every second patient, or 53% of the progression occurs in 10 years of the time. So, Bacillus Calmette-Guerin. This is the vaccine attenuated Mycobacterium bovis, which is used by Morales in his study, and till now it is almost 48 years it is used in the treatment of non-muscle invasive bladder cancer. There are more than 10 strains of the this BCG which is used to install into the bladder. Most commonly used are the Connaught, Oncotype, OncoBCG, Tokyo, Russian, Pasteur, Romanian, and more than 10 substrains are there. But none of them, they are genetically different, but their effect is no different from each other. So here I want to talk few things about the mechanism of the action. How does the BCG work in the bladder cancer? There are 3 steps how the BCG works. First step, infection of the urothelial cell or bladder cancer cell. It goes inside the urothelial cell and the bladder cancer cell. When it enters to the cell into the cytoplasm, it induces the immune response, and from there the anti-tumor effect starts. Let's talk in detail about the each step. What happens? BCG is highly negative charge in its surface, as well as the urothelial cells and cancer cell has also negative charge in its surface. It means negative, there is the law of physics, it repels each other. But in a high concentration, when BCG is given into the bladder, installed into the bladder, it fixes with the extracellular matrix of the urothelial cell and cancer cells, and it mediates attachment and internalization to the urothelium and cancer cell. But how exactly it enters through the cell wall, it is still not understood. When it enters to the cytoplasm of the cancer cell and urothelial cell, it modulates the antigen processing of antigen presenting cells and enhances the surface of expression of major histocompatible complex class 2. The fate of internalized BCG, what happens with those BCG which is inside the cell is still unknown. In second step, when it is in the cytoplasm of the cell, various types of the cytokines can be detected in the urine of the patient. After second days after the installation, macrophages and activated lymphocyte, they produce interleukin 1, 6, 8, and interleukin 17. And especially the interleukin 17, it plays a crucial role in generation of Th helper cell to stimulate the beta cells to produce immunoglobulin. So once the immunoglobulin is produced, helper cells mediated CD4 T cells and CD8 cytotoxic T lymphocytes, they start to kill the cancer cells. Tumor necrotizing factors related apoptosis inducing lesions, it is also known as the trail, and macrophages also they start to kill the tumor cells. Natural killer cells, neutrophils, gamma and delta T cells and macrophages are also stimulated. Thus, BCG kills the tumor cells. So there is, it is a very important publication by Donald L. Lam and Alvaro Morales, who are very pioneer of the research in the BCG in the treatment of non-muscle invasive bladder cancer. In European Journal of Vaccine in 2021, they have published the comparison of only TURBT as a control group and BCG. You can see from this graph, the recurrence-free rate after the installation of BCG is quite high. Rate is more than 70%. In comparison with the only TURBT, it is around 40%. Southwest Oncological Group, study number 8507, they have shown the that comparison of maintenance BCG and only induction BCG. Induction means only 6 installation of the BCG. You can see from this graph with the maintenance course in both carcinoma in situ and TA T1 is quite higher than only induction dose. So they prefer to do the maintenance dose. Another study from Southwest Oncological Group, study number 8216, they compared the doxorubicin with the BCG. You can see from the graph, using the BCG in CIS, in 5 years, recurrence-free survival rate was 45%. With the BCG, in comparison with doxorubicin, it was only 17%. So BCG is still better than the chemotherapy. Recently, there was one publication which compared the BCG with the gemcitabine and docetaxel. They use both docetaxel and gemcitabine as a induction dose. They have shown a bit better result with the gemcitabine and docetaxel, but we should remember we are in the South Asian country. What will be the cost of this treatment with gemcitabine and BCG? BCG is I don't know how much it costs in Pakistan, but it is very cheap in Nepal. So, contraindication for the BCG installation is immunosuppressive patients. In immunosuppressive patients, you should be very cautious because the patient after a BCG installation can develop BCG sepsis. In concurrent antibiotic use, it is not advisable to use the BCG installation because BCG antibiotics can kill the BCG. In febrile status and symptomatic urinary tract infection and macroscopic hematuria, also it is contraindicated because the BCG can be systematically absorbed and it can cause the more adverse events. In muscle invasive bladder cancer and large tumor volume, there is no use of the BCG. So installation of the BCG, installation of procedure comes like this. It should not be used 2 weeks prior to TURBT because from the raw area of the resection site, BCG can be absorbed systematically and the adverse events will be more. Patients should be dehydrated, no food and no fluid for 4 hours prior to BCG installation to keep the bladder empty. And before installation of the BCG, we should put the catheter into the bladder, and all the urine which is in the bladder, it can dilute the BCG, so it should be drained out. And in our practice, we use 80 milligram of BCG. Our people, they could not tolerate 120 milligram of the BCG. A lot of adverse events we encounter with the 120 milligrams, so we use 80 milligram of BCG, which is mixed with 50 milliliter of normal saline, and we install into the bladder. And patient lies in 4 different positions. First, in the position where the resection was made. If it is in the posterior wall of the bladder, patient should lie first on the supine position. Similarly, if it was in the right lateral wall, then the patient should lie first on the right lateral wall, and every 15 minutes he changes his position. But there was recently, I read one publication that after instilling the BCG into the bladder, immediately they send patient to the home, and he can pee after 2 hours, and they do not change the position. It is also started to be performed in some countries. So it is advisable to drain the urine with the catheter, because we know while peeing the urine after installation, the BCG can be embedded in the prostatic urethra or in urethra, and it can develop the granulomatous prostatitis or urethritis. So it is advisable to drain the urine with catheter. No quinolones after BCG should be installed, because we know quinolone is second line of antitubercular treatment, so it kills the BCG into the bladder. The BCG schedule. There are 2 methods of the BCG installation. One is induction, another is maintenance. After 2 weeks after the TURBT, with the above mentioned procedure, we instill BCG into the bladder every week for 6 consecutive weeks. This is the induction dose. Maintenance dose is started depending upon the risk group. I will come in the another slide. Above mentioned procedure, and each week for 3 weeks, in 3 months, in 6 months, another 3 weeks, 12 months, another 3 weeks, such a way, 18 months, 24 months, 30 months, and 36 months. Up to 3 weeks, we install maintenance dose, 27 installation in maintenance dose, and 6 installation in induction dose. It will be total 27 installation in a very high risk group. So here is the stratification of the treatment. In low risk group, if the tumor is solitary, primary, and low grade, after doing the TURBT, immediately within 24 hours after the TURBT, we instill intravesical chemotherapy. In our practice, we instill 40 milligram of the mitomycin. In intermediate risk group, it is advisable to use the TURBT with immediate intravesical mitomycin. Then we start induction dose of 6 doses, and for 1 year, every 3 months, for 3 weeks, we use maintenance dose. There will be the total 18 installation. But in high risk group, we use, as I mentioned previously, 6 induction doses and 21 maintenance doses, and it will be total 27 installation. So BCG is not without adverse events. We should remember in that. The adverse events are more during maintenance therapy. Southwest group, the oncological group, has shown that only 16% of the patient completed maintenance therapy for 3 years. It is, you can see, only 16%, because the complication rates increases with the maintenance therapy. In about 0.4% of the patient, BCG sepsis was encountered. There were published, I don't know how many cases are not published. There were 10 mortalities were published between 2006 and 2011 in 5 years with the BCG sepsis. So adverse events are of the 2 types. In the local, mainly it is the storage symptom of the urinary bladder. It comes with the urinary frequency, mild fever, general malaise, irritative bladder symptom, and hematuria. Those are the common adverse effects of the BCG, which can be treated with the symptomatic treatment. you need not to discontinue the BCG here. But if patient develops the severe adverse effect like granulomatous prostatitis, granulomatous epididymoorchitis, contracted bladder, hepatitis, or pneumonitis, you should stop the BCG instillation and should start the antitubercular treatment. So in conclusion, no one intravesical BCG strain is superior than the other. All the strains are similar. Maintenance dose of BCG is subjected to the risk group, because in intermediate risk group, we do maintenance therapy for 1 year, and for high risk group, we continue the maintenance therapy for 3 years. Higher the dose of BCG causes higher adverse events. Maintenance dose of intravesical BCG installation significantly increases the recurrence-free and progression-free state. Thank you.
Thank you very much, Prem, and wonderful, comprehensively describe the role of BCG, and particularly what we know about how it works. We may not be 100% sure this is exactly how it works, but thank you very much for your presentation. We know that BCG does not work 100%. Nothing works 100% anyways, but there is a significant failure. How to deal with that failure is the topic of the next presentation, and we are very lucky to have Ms. Elsie Mensah, consultant urologist at Guy's St. Thomas's, who is going to talk about BCG failure and how to deal with that situation.
Hi, I'm just, can you see my presentation?
Yes, Elsie, we can. If you can go into the full slide presentation mode, it will be easier for us to see. Thanks.
Yes. Wonderful. Hello, everyone. Firstly, thank you so much for having me on again. It's such a pleasure to be able to join you on this to discuss such a clinically relevant topic. I'm from Guy's and St. Thomas's, consultant urologist since 2020. So BCG failure and its management, a question that plagues every MDT that we have. I think, first of all, when it comes to BCG treatment, there's so many different phrases and definitions that are used, and it's quite important for us to be aware of what these phrases are and what they mean, because misunderstanding each other when we use various phrases means that we can miscommunicate what we're trying to communicate about a particular patient population, and therefore what that patient or hasn't had. These definitions, including BCG failure, BCG unresponsive disease, BCG exposed refractory relapsing. I'm sure I'm going to introduce a few more phrases into the mix as well, just to complicate matters even further. But a lot of these phrases were developed in clinical trial settings just to try to identify a specific patient population that studies are investigating. They have subsequently been adapted into guidelines and then into clinical practice. They do have a use, and they are quite important, these different phrases and definitions, because it helps us to clarify the specific patient population that we're referring to, both in trials but also in clinical practice. Are these patients who've had a little bit of BCG? Are these patients who've had the full course, et cetera, et cetera? What do we mean exactly by some of these phrases that we use? It's important to know what is meant by it, and also what risks are associated with that particular sort of group, and therefore, and also whether or not they can benefit from further BCG. Again, when we talk about recurrence in BCG, because again, this is really what the topic is about, patients who have recurrences despite BCG treatment. What do we mean by recurrence? I think it's always important that we really reflect as to whether this is truly recurrence or whether it was an incomplete resection in the first place. Because I think otherwise it just means that a patient is then put down the line where they may even end up having to have, a radical cystectomy just because they've been mislabeled as having failed BCG when they probably did not have an adequate resection to begin with. And this is where we talk about getting it right first time, because it has such an impact on that patient's trajectory. The second point I'll make here is that low-grade recurrence during BCG treatment is not labeled as BCG failure or as BCG unresponsive disease. And so, in those scenarios, you manage the recurrence, clinically appropriately, and then proceed with your BCG schedule. So low-grade recurrence should not affects that patient's kind of BCG journey. The next point to make before we even start talking about BCG failure or BCG unresponsive disease, etc., is this whole concept of adequate BCG. Because when it comes to discussing BCG failure or unresponsive disease, how much of the BCG does the patient need to have to be considered as having an adequate BCG? We know practically that due to issues with supply, due to issues with tolerability, symptoms, etc., a lot of patients, very few patients actually have the sort of textbook course of BCG. So what is adequate? Well, the EAU guideline kind of defines that a little bit for us. And they say that adequate BCG is defined as someone who has completed at least 5 out of the 6 initial induction course of BCG, or in those patients who we decide to give a reinduction course to, they need to have had at least so their initial 5 out of 6, and also at least 2 out of the 6 of the second induction course, or 2 out of their 3 maintenance therapies. So to be defined as having had adequate BCG. So therefore, it means that when you have a patient in the MDT and they have a recurrence, and we're trying to decide whether or not they failed BCG or not, it's important that we have quite accurate documentation of exactly what BCG this patient has had, how much have they had. And I don't know about your units, but this can be quite challenging in terms of us keeping good track of the documentation and having that contemporaneous information available during your multidisciplinary meetings to make a decision as to whether that patient has had what we would clinically define as adequate BCG. You'll also find that in several of the trials going on, they often specify how much BCG a patient needs to have had before they can be eligible for these trials. So again, we need to have this information easily to hand, both to help with our management decisions, but also just to help categorize where that patient fits in this whole BCG paradigm. There is this concept of BCG exposed rather than BCG failure, i.e. these patients who have had some BCG, but they haven't quite had this whole adequate BCG, but we'll talk about that a little bit further. So BCG failure, it's really sort of defined as patients who have high-grade disease that's detected during or after intravesical BCG treatment. Now, often, there is a school of thought that we should try and move away from actually using the phrase BCG failure, because it's such the patients that this phrase applies to, they're so heterogeneous, and so many different things can be meant by individuals when they say somebody has failed BCG. So we need to dig down further and decide exactly what are we trying to say about this patient. So look at the various different definitions. So there's BCG refractory disease. These are patients, and we'll go into each of these in a bit more detail, but BCG refractory is basically patients who did not respond to BCG at all. BCG relapsing, these are patients who on the whole relapsed after an initial response. And this group can be those who relapsed early, so early relapses versus late relapses. These are patients who initially responded and then relapsed. And then we come to the BCG unresponsive group, and I'll talk a bit more about what this actually means. And this is an important group, and you'll find it's actually the group that most people are referring to when they say when they describe someone as having failed BCG. What they actually mean is that that person is BCG unresponsive, because this is the specific group where the guidelines tell us that further BCG is unlikely to be of benefit. And this includes all the BCG refractory patients that we've already discussed, and also the early relapses, so not the late relapses, but we'll talk about that in a bit more. And of course, BCG intolerant diseases comes up quite a lot clinically. So BCG refractory disease, this is an important group. Bear with me, I'm just going to change my view. Okay, so this includes patients, so all in all, these are patients who did not respond to BCG. So that's defined as anyone who is found to have high-grade T1 disease at the 3-month check, cystoscopy and biopsy. So they have their induction there, they're going to have a GA cystoscopy and biopsy. If that investigation comes back showing this G3T1 disease, that patient is defined as having BCG refractory disease. Again, in patients who have high-grade or G3TA disease at 3 months, and then also at 6 months, that's because normally if it's just at 3 months, you would normally the guidelines would say that you can give a reinduction course of BCG. So at 3 months and then at 6 months, you would define that as having BCG refractory disease. When it comes to CIS, again, if they have CIS at 3 months and persists into 6 months after they've been reinduced, then you would say that that patient has BCG refractory disease. Mainly because at 3 months, if someone has pure CIS and then they're found to have persistent CIS at their first 3-month check, if you give them, if you re-challenge them with BCG, 50% of these would respond. So if someone has CIS at 3 months, you don't class them as having BCG refractory disease. It's only if it persists despite that reinduction into the 6-month check. And then the final group would be those patients who were found to have high-grade disease during their maintenance BCG. So they went through the induction okay, but then during the maintenance, you find that they have G3T1 recurrence, or so that again is classed as BCG refractory disease. And you will remember from the previous slide that these BCG refractory cases all kind of get swallowed up in this whole BCG unresponsive paradigm. Okay, so I've talked about BCG refractory disease. Now I'll talk about BCG relapsing disease. As I said before, the two groups of this, so the early relapses, and that's the more important group because these are the patients who have high, the early basically means that you have high grade, so you have high grade T1 or TA disease within 6 months, or CIS within 6 months after BCG exposure. And then late relapses are those who have it later on, so after 12 months with CIS, or after 6 months with high-grade disease. So the early relapses, if you recall from the previous slide, also goes into the BCG unresponsive group because those patients it's felt that they have a higher risk profile than the late relapses. Okay. So now we'll talk about BCG unresponsive disease. Again, this is normally what people are referring to when they say that someone has failed BCG. This group includes all the BCG refractory patients and also all the early relapses. Okay, so high-grade T1 or TA within 6 months or CIS within 12 months of adequate BCG exposure. Again, very important that, we're remembering that the patient has to have had adequate BCG. So if due to tolerability issues or due to supply issues, the patient did not actually have, the right number of, let's say if they only managed to have 4 out of the 6 doses of induction BCG, that would not be classed as having adequate BCG. So strictly speaking, you should then not put that patient in the BCG unresponsive category. So they definitely need to have had adequate BCG as defined by the EAU guidelines. This is 5 out of 6 of induction plus 2 out of 6 of second induction or 2 out of 3 of their maintenance. It's not that easy to remember all the time, and often we're having to sort of review back just to double check that we're putting patients in the correct group. Okay, so then that picture basically just shows the BCG unresponsive disease includes all BCG refractory patients and then the early relapses. So what do you do when someone has BCG unresponsive disease? So your refractories and the early relapses. For this group, it is felt that further BCG is unlikely to be of benefit just due to the risk profile. And therefore, the primary recommendation would be that that patient is counseled and offered radical cystoprostatectomy. Of course, this is often a difficult conversation to have in clinic because these patients do not have muscle-invasive disease, and yet you're having a cystoprostatectomy discussion with them. It's important during these counseling sessions that patients are aware that the reason we have this discussion, they have not responded adequately to BCG, but also we know that if they have upfront cystoprostatectomy at this stage, their sort of prognosis is a lot better than waiting for them to have muscle-invasive disease. Of course, there will be some patients who either really do not want cystoprostatectomy despite being fit for it, or patients who are not actually fit enough for radical cystoprostatectomy. In that scenario, there are other bladder preservation options can be discussed, including clinical trials as appropriate. Some of these options can be discussed with these patients include hypothermic mitomycin C, which is either given as Hyvec or kind of Synergo. So either the mitomycin is heated within the bladder or outside the bladder and put into the bladder. Very important to understand that these are not first-line treatments, and so patients who are being offered this, of course, need adequate counseling, but it's also better that it's done within the context of trial or in an investigative unit, so that outcomes can be adequately monitored, and also so that proper data can be provided to the urology community as a whole in terms of how much benefits patients derive from this. A few things currently being investigated. These include sort of systemic immunotherapy. I'm sure a lot of you through the various conferences have heard of the pretzels and the TAR 200, which was investigated as part of the Sunrise 1 study, which is where this pretzel-looking thing is placed in the bladder intravesically, and then it releases gemcitabine, and it's been found, or it's still being investigated, but the early results seem quite promising in terms of outcomes for non-muscle invasive disease. There are other things being investigated, including combination of systemic and intravesical chemotherapy, as well as one of the trials, Duran's trial, looking at immune checkpoint inhibitors with vaccine. So there certainly seems to be, I don't want to say explosion, that might be over the top, but there seems to be a bit more excitement into looking at other options with this BCG unresponsive cohort of patients. But clearly, obviously, these are all still under investigation, so they're not first-line treatments, but it's important that our documentation is correct in terms of what BCG patients have or haven't had, etc., because this will be important to be able to identify correctly which patients may be suitable for any of these trials so they can be put forward for them. Now, coming back to discuss the BCG relapses, the late relapses, as I said, these are patients who initially responded but relapsed, after 12 months or so. So for these patients, it is felt that their risk profile is better than those who relapse early, and therefore for these late relapses, it's quite reasonable to offer complete TURBT, so complete resection to ensure that the bladder is as clean as possible, and then offer a repeat challenge with intravesical BCG induction and maintenance. Often in my practice, if I would normally use added cystoscopy techniques such as photodynamic diagnosis or blue light cystoscopy, mainly because I just want to do everything I can to ensure that the bladder is as disease-free as I could possibly get it and as optimized as possible before putting them through another BCG course. Again, these patients should still be offered or should still have a discussion about radical cystoprostatectomy, and some may go for that, but it's not unreasonable to offer these late relapses another challenge with BCG. In the sort of newest iteration of the EAU guidelines, they talked a bit more about this BCG exposed group. So this is yet another phrase that's been thrown into the mix. To be honest, it's something that we've all sort of been dealing with, but I guess it's just been put out there as an actual definition or as an actual group that we can refer to. So essentially, the BCG exposed group are those patients that fall between BCG naive and BCG unresponsive disease. So they're not BCG naive because they've had some BCG, but they don't quite meet the criteria for BCG unresponsive disease, either because they haven't had adequate BCG or they just, or their recurrence wasn't sort of early or immediate. So of course, that would include all the late relapses that we've just talked about. So, I've just attached the 4 definitions that are given in the EAU guidelines, but essentially it's all those patients with, high-grade TA or CIS at 3 months after the induction BCG, because of course, as we remember, we wouldn't automatically class those patients immediately as having BCG unresponsive disease, or those patients who have delayed relapse after adequate or after inadequate BCG. So these are BCG exposed patients, and just remember that they have not failed BCG, and therefore it may be appropriate to re-challenge them with BCG after ensuring that the bladder is optimized with a good, thorough TURBT. There are also, there are always some troublemakers in the group. So there are some people that are challenging this whole BCG unresponsive paradigm. I'm talking about this because it's a conversation that's going on, but it's just important to firstly state that this isn't kind of current everyday practice. But essentially, there are researchers that are saying, are we really sure that all these people that fall into the current EAU guideline of BCG unresponsive disease, are we sure that that none of them can benefit from further BCG? That's basically the question that's being asked, because the guidelines are saying to us that these patients who have BCG unresponsive disease, it's unlikely they'll benefit from further BCG, so offer them cystectomy or trial. But these researchers are saying, actually, this group is just so heterogeneous that maybe some of them could benefit from further BCG. So these researchers looked at some patients of theirs who had a BCG unresponsive disease, but who went on to still have some BCG. Of course, it's retrospective data, so some of these patients actually went on to have BCG before the current definition of BCG unresponsive disease was out there and was in clinical practice, but it just gives us the opportunity to know what actually happened to these patients. What they're saying is that selected patients may still benefit from what they define as rescue BCG. And rescue BCG in their hands means that having, another kind of induction course, at least 6 doses, or continuing their maintenance course. So they reviewed about 172 patients who we would currently class as having BCG unresponsive disease. And of those, about 36 had high-grade disease, and that included T1 disease, CIS only, or CIS and high-grade disease. And prior to having further BCG, all these patients underwent a complete TURBT, and these patients were followed up for a median of 4.7 years. And they found that 75% of their patients actually remained disease-free, with a median duration of response of about 83 months. And even within this group, they found that patients who had sort of high-grade T1 disease, so these are kind of the refractory patients, had slightly lower benefits than those who simply had BCG failure, let's say, CIS, but has had adequate BCG and still has a recurrence, so is deemed as having BCG unresponsive disease. So in those patients, actually, the response was better, was about 85%. And I think the point that these researchers are making is that, having 75% remaining disease-free, that's quite equivalent to some of the studies that were encouraging these patients to be put into when they fail BCG. So therefore, if BCG can offer them the same kind of response, is it not worth looking at? There are several caveats that I will mention, though. The first is one that I've already mentioned, which is that this is not current practice, and therefore, I'm not suggesting that everyone goes to their units and starts doing this. But if it's being done, it should be as part of a, trial, or as part of very close follow-up and counseling. But another caveat is that all these patients were treated in a tertiary center where all the TURBT and all the bladder cancer care was provided by expert bladder cancer surgeons. And therefore, we do not know if these results that they got can be extrapolated to all the units everywhere. Additionally, naturally, there was some patient selection. So in patients who had, worse disease profiles, like, multifocal, very high volume disease, patients with hydronephrosis or lymphovascular invasion or ovarian disease, none of those patients were included in those ones who had this sort of rescue BCG. So I guess there's, so it shouldn't just be blindly applied to all patients that fall in the BCG unresponsive category. But I guess the thing that they're saying we need to look at again is, can selected patients with good risk profiles who fall within this BCG unresponsive paradigm, can they be rescued with some more BCG? And I guess we're going to watch this space and see. So in summary, in patients who have BCG unresponsive disease, and I am specifically using BCG unresponsive because I think saying BCG failure kind of clouds the picture, because there's so many different groups that fall within that. So in patients who have BCG unresponsive disease, the primary offer should be radical cystectomy, if they're fit enough for it and if the patient agrees to it. If not, there are a few clinical trials that are going on, but be mindful of the fact that a lot of the patients with these bad profiles, such as with hydronephrosis or with variant histology or lymphovascular invasion, etc., a lot of the trials would exclude those patients as well. So those patients may not even be able to get into these trials either. So, it's not plain sailing for these patients who have not responded to BCG, who also don't want a cystectomy. So I think it's quite reasonable to consider the question that's being asked by researchers about whether selected patients could benefit from rescue BCG. Secondly, in BCG exposed patients, and I think this is a phrase that, we have been using in our practices, but maybe not specifically saying BCG exposed, but these are patients who either had inadequate BCG or have had adequate BCG, but have relapsed later on in their journey. These patients, please remember that they do not all automatically need to go down the line of radical cystoprostatectomy. They can be offered a re-challenge with BCG if appropriate and if the patient does want it. And finally, remember that low-grade recurrence does not constitute BCG failure or BCG unresponsive disease, and therefore the disease should then, their individual recurrence, low-grade recurrence should be managed, and then their BCG schedule should be reinstated as normal. Thank you so much.
Thank you, Ms. Spencer. Wonderful talk. And particularly those difficult phraseology that we have defining the various BCG failure, very, very nicely explained. Thank you very much. Most of the questions have already been addressed. Just one question to Professor Prem Gyawali. We know that BCG does not work or is not very effective for patients who are immunocompromised. Do you consider patients who've got poorly controlled diabetes or who had previous chemotherapy or a renal transplant or any other transplant surgery and immunological agents as a contraindication to use of BCG?
No, it is just said that the immunocompromised patient, if we use the BCG in those patients immediately after the TURBT, if there is any chance of systemic absorption of the BCG, the chances of developing BCG sepsis is high. That's why it was contraindicated in immunocompromised patients. But in this chart, I show a few questions that everybody is asking why on right position to lie down. I didn't tell to lie down on the right position, right side. I told to lie down on that position where was the tumor before TURBT. If it was on the right side, he should lie on the right side. If it was posteriorly, he should lie on the supine position. There is nothing to lie on the right side to start with the BCG installation. I want to clear out this one.
Thank you. I think we have some good discussion about changing position and giving a bed to a patient in an outpatient clinic for 1 hour, which is often very difficult in most busy clinics to let patient lie in a clinic bed for 1 hour. But yes, I think it's something that started off with mitomycin and is now being practiced with BCG about changing position or getting the drug and walking out of the clinic and peeing hour and a half later with little fluids so that it doesn't get diluted. So, ladies, gentlemen, thank you very much for a very wonderful presentation. And I think the difficult concepts concerning the intravesical treatment of both chemotherapy and BCG is very clearly defined by our learned speakers. Next session is on 16th of November, and we're going to present few cases. Our panel would include, again, Ms. Mensah from UK, Professor Mitsogiannis from Greece, and Mr. Mazhar Sheikh from Blackpool, from Oldham, sorry. And see you again in 2 weeks' time. Until then, thank you very much and have a very good evening and weekend.
Thank you very much and good night.
Thank you, Prof. and everyone. Take care. I, J, E, N.
O I U Y E D R E